Hello guys, for people who don't know me, I'm Dr. Bhargavi Boppana. I have completed my MS General Surgery and I'm going to join my super specialty in surgical gastro. We have started this channel called as Average Surgeons to educate people, to show our interest towards general surgery and to help fellow surgeons. Thank you. Let's start a discussion about giant duodenal ulcer. What is giant duodenal ulcer? Why we should know about it? What are the complications we'll face? Uh, Giant duodenal ulcer is any ulcer which is greater than 2 centimeters or so. It is called as giant duodenal ulcer, Graham's patch. So let's start. So what is the definition of giant duodenal ulcer? Giant duodenal ulcer is full thickness peptic ulcer of duodenum, full thickness perforation of the peptic ulcer of duodenum when it is greater than 2 centimeters. In some textbooks greater than 3 centimeters it is called as giant duodenal ulcer. So what are the things which you see in giant duodenal ulcer? There is substantial tissue loss and there is of the duodenal bulb. Second, there is a marked edema. There is a marked edema, fibrosis, and there is highly friable tissue. So even though you try to suture by Graham's patch, there is high chances of cut through. And third thing is there is high amount of gastric and biliary pancreatic secretions. You know the pancreatic secretions are fat, lysis rich. So all the omentum, all the part of mesentery will be saponified because of these tissues. And you know the gastric secretions are acid, so this acid secretion contaminate all part of your entire abdomen. So in whatever procedure you do, there are different sorts of procedure. There are resection procedures and there are non-resection procedures. Whatever procedure you do, it is very important to give very good amount of wash. 7 to 8 liters of wash is very important whatever procedure you do, because lot of contamination, lot of secretions, lot of pus flakes, everything will be there in these sort of perforations. So while a perforation is dangerous, there is extensive tissue loss, there is friable and inflamed edges. So what you have, whenever you take a suture, there will be cut through and there is a high amount of biliary pancreatic drainage secretions, 2 to 3 liters, all the gastric juice, biliary juice, as we already discussed. So what are the different options we have? So we have the procedures called as resection procedures and we have the procedure called as non-resection procedures. The non-resection procedures, you know, the omental patch, Graham's patch, the Graham's patch, the Graham's patch. The first, for it's a good point. The first Graham's patch is not which is developed, which is invented. It is Selene-Jones technique which is informed. After that, the Graham's patch has been modified from the Selene-Jones technique. So what are the different procedures that there are in non-resectional procedures? There is the omental paste procedures, that is omentopexy, which we do regularly, the omental plugging and the free omental plug. The second one, the tube braced procedures, the famous triple tube techniques, and the third one is the jejunal braced procedures, jejunal braced repairs. What are the resectional techniques? The resectional techniques are highly morbid and you have to choose it very properly, very stringently. You should evaluate and you should choose this resection techniques. You are, because the patient is already in shock, the patient presents with shock and major tissue loss, and at that point you start doing the 4 or 5 hour procedure. It is very important for patient to be alive so that you can further think. So what I want to tell is, first think about the damage control part, whether the surgery you are doing is a damage control part you are doing or the definitive surgery you are doing. So always in the case of emergencies, always go for damage control surgery. So what are the different resection parts, resection techniques? First, the antrectomy and defect closure. You do stomach antrectomy, the antrum part of the stomach you will cut, and the duodenal part you will do the defect closure. Second one, the gastric disconnection. So you entirely connect the gastric part with the duodenum, gastric body partition. And the fourth one is duodenectomy with gastrojejenostomy and tube duodenostomy. So let's discuss each of this procedure one by one, so you'll get a clarity. Yeah, the first you people all know the resectional procedures, the omental basic procedures. You know the modified Graham's patch, I need not tell. Then what is this intraluminal plug? What is this intraluminal plug? You do nothing. So you have your RT, you ask your anesthetist to negotiate RT through the duodenum, and you will make sure that at the part of perforation you will get the RT out, and you tie this omentum nice omentum to the tip of the artery, and you ask your anesthetist to pull your artery. So this omentum comes and sits in the perforation. See, the NG tube is advanced to the gastroduodenal defect. Tip of the vascular omental pedicle is anchored to the tip of the NG tube. You will pull 5 to 6 centimeters of the omentum into this duodenal defect. So your duodenum, your omentum goes and sits in the perforation, and later in the outer margin you will normally suture as your Graham's patch. This is your intraomental patch. And the second one, the famous tube-based procedures. What is this tube-based procedures? It is a triple loop technique, or it's a Bernese technique. What is this technique? So what you will do actually, so what is the important thing in this perforation, duodenal perforation repair? So the first thing, you have to make sure the defect, the wherever you are closing, it should not be exposed to the secretions. It should not be exposed to the gastric secretions. Why? The gastric secretions will dissolve your suture material, or will make sure the wound burst off. So you should make sure the gastric secretions doesn't touch your closure. Second, you should make sure the duodenal secretions doesn't go back. You should make sure it heals properly. So based on that, what we do, see this beautiful photo. So this is the photo of your omental patch, omental plug pull through. The second one is this technique. So what you will do, so you have closed your duodenum. Yes, you have closed your duodenum. You are diverting all your gastric secretions by the gastrostomy. So you are keeping a tube into the stomach. This is your tube 1. The second thing is retrograde duodenos. The second thing is retrograde duodenostomy. So you are keeping a tube into the duodenum. So whatever secretions comes into the second part of the duodenum, be it be bile or be it be pancreas, is being diverted. The third thing is you are giving a feeding jejunostomy. Okay, it's a feeding jejunostomy. So you can give food to the patient. So the general condition of the patient improves. So that it is a 3-tube procedure. What are the 3 tubes? You will keep a gastrostomy, so all the gastric secretions gets diverted. The second part is retrograde duodenostomy, so all the bile and pancreatic secretions get diverted. So your sutured part gets healed. So it doesn't, none of the secretions goes and irritates your sutured part. And third one, you will keep a feeding jejunostomy so that the patient gets nutrition. See, you have done the duodenography, you have closed it, अच्छे से. Then you are doing retrograde duodenostomy, right? Then you are doing gastrostomy, yes. And they're doing the feeding jejunostomy, yes. Then what is the third procedure? You know, the jejunal based procedures. What you do in jejunal based procedures? So there is no omentum. Imagine the omentum, everything was gone. The acid has digested, the pancreatic enzymes has digested the omentum. So there is a technique called as Thal procedure. What is this Thal procedure? It's nothing but you will get the jejunum part and you will keep the jejunal serosa on the perforation and you will close. So what is this jejunal serosal patch? If there is a very large tissue loss and whereas omentum is unavailable, then you go with the jejunal serosal procedure. What you do? You keep a loop, you get a loop of jejunum and you will make sure the serosal patch sits on the defect and you will close it. So these are the non-resectional procedures. Then what are the resectional procedures? What are the resectional procedures? The most important and most beautiful technique is pyloric exclusion procedure. Pyloric exclusion. So what do you do in pyloric exclusion? Whenever there is a huge amount of duodenal destruction and there is severe peritonitis, so you have to bypass, you have to make sure all the contents doesn't go and touch the sutured site. So what you are doing, you are excluding the pylorus and you are making sure the acid secretion, whatever is there, it is not going into the duodenum and go to the sutured part. So what you are diverting all the gastric secretions by a GJ, that is gastrojejunostomy, and you are suturing the duodenum, which is duodenography. And the third thing, okay, so how are you disconnecting these two parts? So you are keeping suture at the pylorus with the absorbable suture. So what happens after some days? These are absorbable sutures, right? At some point they will cut through and give away. They will give away and they'll go off. So then the gastric secretions come to the duodenum. So this, till the time these sutures go off, it gives the time for duodenum to heal. So what do? You do gastrostomy. You will do gastrostomy. You open the anterior wall of stomach, right? And what do? You go from the anterior wall of stomach. From the anterior wall, so you have opened the anterior wall of stomach. So you went to the pylorus and you have created an absorbable suture at the pylorus. See, locate the pylorus ring from the inside of the stomach, suture. Close the pylorus internally with heavy absorbable suture such as PDS and Vicryl. So you have closed it. Then you will close the duodenal defect, which is duodenography, and then you do gastrojejunostomy. So what happens? See, now the acid which is coming directly goes to the jejunum, right? And the duodenal secretions will go down. Some people tell add a retrograde duodenostomy also, so to bypass this duodenal secretions. So here a tube comes, so it deviates everything. Okay, fine. So all these secretions can be tubed by retrograde duodenostomy. After some days, the sutures which you have kept here get cut through, goes off naturally. So by the time your duodenal wound might have healed, so later the food goes अच्छे से to the duodenum and everything happens nicely. Yes. Almost every suture tends to cut through the pylorus and the gastroduodenum outputs opens in 2 to 3 weeks. How beautiful procedure is this? See. Then coming to all the morbid procedures, I feel in the resection procedures, this thing is very important. What the pyloric exclusion technique. Later the antrectomy and the gastric disconnection. So what do you do in antrectomy? So you cut the antral part of the stomach. You will cut the you will cut the antral part of the stomach. You have closed the antral part of the stomach. Then you have closed the duodenal defect. And you have done a feeding jejunostomy. It's simple, same as the tube procedure, but then you are doing antrectomy also. So you have done a gastrostomy, you have done an antrectomy, you have closed this, and you have done duodenostomy, and you have done a feeding jejunostomy. Why this is very dangerous is now, the duodenal blowout, right? So there is high chances of duodenal blowout because you are creating a free duodenal suture here, free end of the duodenum, right? Sutured free end of the duodenum. There is high chance of duodenal blowout. So what do? You do an antrectomy and duodenal closure. Indication is the same, proximal whenever the more tissue loss. So you close the duodenal stump. Okay, then you will place a duodenostomy tube as I already told you. Then you will cut the antrum. Yes, and you do a feeding jejunostomy. Fine. Then what do you do? If at all the patient is extremely toxic, the vital parameters, nothing is good, then what do? First you do an index surgery, then you go for a damage control protocol. You do an index surgery. What do? First you do debridement. अच्छे से you will give wash, everything 8 to 9 liters you give wash. You will do simply defect closure. Then what do? You do gastric disconnection. You do nothing. You disconnect the gastric passage. What is the easy way of disconnecting the gastric passage? You do antrectomy. You will cut, you will अच्छे से suture, and you will do gastrostomy. See, you will do gastrostomy. Then you wait. You make sure the patient is stable. The patient is stable. The vital parameters are normal. After 48 hours, after 72 hours, once the patient becomes vitally normal, vitally stable, then you take the patient to OT, and then you take the recraptotomy, and you will make sure the continuity is restored. How do you restore the continuity? Be it a row and Y technique or Billroth 2. Okay? Mostly row and Y technique, because all the complications with Billroth 2 will not happen with the row and Y technique. You will do the definitive restoration procedure. Then the less important are the gastric body partition. See, the gastric body partition you are doing the same funda. And then one more technique. So you will do the duodenectomy. Then you will do tube duodenostomy, true. Then you will keep gastrojejunostomy. Then you will do feeding jejunostomy. Then you will do retrograde gastrostomy. So this is catheter technique. Whenever you close the defect, the duodenography, in whatever procedure you do, you make sure you keep a wide bore tube, wide bore drainage, be it 32 number drain, whatever it is, just niche of this duodenography. Why? Whenever the leak happens, if at all that your duodenography had leaked, immediately you have to know out. So for that you keep a wide bore drainage tube just below your duodenography. So all these are the important things. So small duodenal perforations, in a small duodenal